Welcome to NCLEXReviewPro, your trusted e-learning platform for focused, high-yield NCLEX preparation. In this Q&A session, we're tackling neurological and neuro-pharmacological nursing, one of the most reasoning-heavy and test-focused sections of your exam. Here, every question has a purpose. We'll work through all 6 NCLEX question types, from multiple choice and select all that apply, to matrix grids, drop-down cloze items, ordered response, and highlight the text questions. Each one is designed to challenge the way you think, reason, and prioritize, just like the real exam. We'll break down 28 high-yield NCLEX-style questions, one by one, explaining the logic behind every correct answer and the traps behind the wrong ones. Each explanation connects clinical reasoning to practice, so you don't just memorize facts, you learn to think like a nurse. So stay with me, take notes if you need to, and let's build the kind of clinical confidence that gets results on exam day. This is NCLEXReviewPro. Let's begin. All right, let's begin our first question. A nurse is assessing the motor and sensory function of an unconscious client who sustained a head injury. Which technique best tests the client's peripheral response to pain? Option 1. Apply a sternal rub to the chest. Option 2. Apply firm pressure to the nail beds. Option 3. Apply upward pressure to the orbital rim. Option 4. Squeeze the sternocleidomastoid muscle. Take a moment. What do you think? Which one truly measures a peripheral pain response? If you chose option 2, apply firm pressure to the nail beds, you're correct. Here's why. Peripheral response testing checks the integrity of the spinal cord and peripheral nerves. The nail beds are the most distal part of the body, so applying pressure there gives the most accurate read of peripheral motor and sensory function. The other options, the sternal rub, orbital pressure, or muscle squeeze, are central pain stimuli. Those are used to evaluate brainstem or cerebral activity, not peripheral response. Using distal stimuli helps the nurse localize the level of neurological injury while avoiding unnecessary trauma. Now, a quick NCLEX alert. Always document the exact stimulus you used and how the client responded. For example, withdraws to pain or no movement. Avoid repetitive or harsh central stimuli. They can easily bruise or injure the patient. And here's your clinical coach takeaway. Think in sequence. Start with peripheral, then central, then move into your Glasgow Coma Scale scoring. That order keeps your assessment systematic and safe. Alright, that's question 1. Let's keep the momentum and move on to the next one. Here's a matrix grid type question on vital sign trends in increased intracranial pressure. A nurse is caring for a client with a severe head injury. The healthcare provider suspects rising intracranial pressure, or ICP. You review the client's latest vital signs and need to decide which trends are consistent with increased ICP and which are not. Take a second and think through what happens in the body as pressure builds inside the skull. You notice these findings: an increasing temperature, a decreasing pulse rate, irregular or slowing respirations, and an increasing systolic pressure with a widening pulse gap. All 4 of these trends point toward rising intracranial pressure. Now, on the other hand, a rising pulse rate and a drop in blood pressure suggest shock or hypovolemia, not ICP elevation. So here's the correct interpretation. Increasing temperature, yes. Bradycardia, yes. Irregular respirations, yes. Widening pulse pressure, yes. Tachycardia and hypotension, no. Let's break down why. As intracranial pressure rises, the brainstem senses that blood flow to the brain is being reduced. To compensate, the body increases the systolic pressure to push more blood into the brain. That's the widening pulse pressure you see. At the same time, baroreceptors trigger a vagal response that slows the heart rate, causing bradycardia. And as brainstem pressure increases, the respiratory center is affected, leading to irregular or slowed breathing. This classic pattern, high systolic pressure, slow pulse, and irregular respirations, is called Cushing's Triad. It's a late and dangerous sign of rising intracranial pressure. Now, what about the incorrect options? Tachycardia and hypotension move in the opposite direction. Those findings are typical of shock or volume loss, where the body is struggling to maintain perfusion, not of Cushing's Triad, where the body is forcing blood into the brain against pressure. Here's your quick NCLEX memory hook. Rising pressure, slowing pulse, widening gap. Say it once more. Rising pressure, slowing pulse, widening gap. Here's a drop-down closed-style question on preventing increased intracranial pressure during routine activity. A client is recovering from a traumatic head injury. The nurse wants to know whether the client understands how to avoid raising intracranial pressure during self-care. Complete this sentence in your mind. The nurse recognizes correct understanding when the client: Option 1. Blows the nose firmly after sneezing. Option 2. Does isometric leg exercises to strengthen muscles. Option 3. Coughs vigorously to clear secretions. Option 4. Exhales slowly while repositioning in bed. Think for a moment. Which action actually prevents a spike in pressure inside the head? If you chose option 4, exhales slowly while repositioning in bed, that's correct. Here's why. Any activity that increases intrathoracic or intra-abdominal pressure, like coughing hard, holding your breath, blowing the nose, or doing isometric exercises, also increases intracranial pressure. It's the same Valsalva mechanism that traps blood in the chest and sends pressure upward into the skull. When the client exhales slowly during movement, the glottis stays open and the venous blood can flow freely from the brain back toward the heart. That prevents pressure spikes and keeps cerebral perfusion stable. Remember this NCLEX alert phrase: closed glottis equals closed flow. Holding the breath or straining traps blood in the head and drives the pressure up, one of the easiest test traps to miss. And here's your clinical coach takeaway. Teach every neuro or post-craniotomy client to exhale during exertion, whether they're turning, lifting, or using the toilet. Avoid bending, coughing hard, or straining. Keep the head midline and the bed elevated about 30 degrees to help venous return. Alright, that's question 3. You're doing great so far. Let's continue to the next one. Here's a highlight the text type question on recognizing cerebrospinal fluid leakage in a neuro patient. A client is recovering from a basilar skull fracture, and the nurse notices clear drainage leaking from the nose. You read the observation note and need to highlight the 2 findings that confirm the fluid is cerebrospinal fluid, or CSF. The note says, the drainage from the client's nose separates into concentric rings on the gauze dressing and tests positive for glucose. So, which phrases confirm that this is cerebrospinal fluid? If you highlighted separates into concentric rings and tests positive for glucose, you're absolutely correct. Here's why. When CSF leaks, it forms what's called a halo sign, a central bloody spot surrounded by a yellow clear ring. That's your first cue. And second, CSF contains glucose, while normal nasal mucus does not. Those 2 features together confirm a dural tear and CSF leakage. Now, a quick NCLEX alert. Never suction or pack the nose or ear of a client with a suspected basilar skull fracture. It can push bacteria inward, cause infection, or raise intracranial pressure. Always document the drainage color, amount, and the glucose test result. Your clinical coach takeaway. On the NCLEX, look for keywords like clear drainage, halo ring, glucose positive, or basilar skull fracture. Those always point toward CSF leakage, and the nursing priority is infection prevention and close neuromonitoring for meningitis risk. All right, that completes question 4. Let's move on to the next one. Here's a select all that apply question, a priority-based safety scenario. A client with a known seizure disorder suddenly begins to have a generalized tonic-clonic seizure while in bed. What actions should the nurse take? Select all that apply. Option 1. Loosen any restrictive clothing around the neck or chest. Option 2. Restrain the client's limbs to prevent injury. Option 3. Remove the pillow and raise the padded side rails. Option 4. Position the client on one side with the head slightly flexed forward. Option 5. Keep the curtain closed and the room door open for quick staff access. Pause for a second. Picture the scene and think about your safety priorities. Which of these actions truly protect the airway and prevent injury? The correct selections are options 1, 3, and 4. Let's reason it out. Loosening clothing allows the chest to expand freely and keeps the airway open. Removing the pillow and raising padded side rails protects the head and prevents impact injuries during convulsions. Positioning the client on one side with the head flexed slightly forward keeps the airway clear, lets saliva drain, and reduces aspiration risk. Now, the actions to avoid. Restraints should never be used. Strong muscle contractions can cause fractures or soft tissue injury. And keeping the door open might let help arrive faster, but it compromises privacy and adds unnecessary noise and distraction. Here's your quick NCLEX safety pattern to remember. Position, protect, observe, document. If a question asks, what should the nurse do first during a seizure? The answer is always about airway and safety. And after the seizure ends, your clinical coach reminders. Keep the client on the side. Check vital signs, oxygen saturation, and level of consciousness. Document the time, duration, movements, and recovery. And stay with the client until they're fully alert. Simple steps, but they save lives and score big points on the NCLEX. All right, that completes question 5. Let's move on to the next one. Here's another select all that apply question, this time focused on stroke assessment and cue recognition. A nurse is caring for a client recovering from a left hemispheric stroke who now has complete right-sided hemiparesis. Which assessment findings should the nurse expect? Select all that apply. Option 1. The client is aphasic. Option 2. The client has weakness on the right side of the body. Option 3. The client has complete bilateral paralysis of all limbs. Option 4. The client shows weakness on the right side of the face and tongue. Option 5. The client cannot move the right arm but can walk independently. Option 6. The client performs daily activities independently despite weakness. Pause and reason this out. The stroke was left-sided, so which side of the body will show weakness? And what happens to speech when the left hemisphere is affected? The correct answers are options 1, 2, and 4. Let's break it down. Hemiparesis means weakness of one side, not paralysis of all 4 limbs. A left brain stroke produces right-sided motor deficits and often causes aphasia, difficulty speaking or understanding language, because the speech centers, Broca's and Wernicke's areas, are located in the left hemisphere. Cranial nerve fibers cross in the medulla, so right facial and tongue weakness also appear. Options 3, 5, and 6 don't fit. Bilateral paralysis describes spinal cord injury, not stroke. If the right arm is completely immobile, the client would not walk independently. And total independence with activities of daily living early after a stroke is unrealistic. Most clients need assistance with feeding, bathing, and mobility. Here's your NCLEX alert to lock it in. Opposite side equals opposite brain. Left brain stroke, right-sided weakness and aphasia. Right brain stroke, left-sided weakness with poor spatial awareness and impulsivity. Now your clinical coach takeaway. When caring for a hemiparetic client, always support the affected limb during repositioning. Encourage use of the unaffected side for daily tasks. And when aphasia is present, use slow, calm communication with short, simple instructions. Alright, that completes question 6. Let's keep going to the next one. Here's a multiple choice question focused on family education for a client with homonymous hemianopsia. A client recovering from a stroke has homonymous hemianopsia. That means loss of the same half of the visual field in both eyes. The nurse is teaching the family how to keep the client safe and independent at home. Which statement by the family shows correct understanding of the teaching? Option 1. We need to discourage wearing eyeglasses. Option 2. We'll place items on the side with vision loss to encourage awareness. Option 3. We'll approach the client from the side where vision is impaired. Option 4. We'll remind the client to turn their head and scan toward the lost visual field. Take a moment and think. Which action actually helps the client compensate for the vision loss rather than making it worse? The correct answer is option 4. We'll remind the client to turn their head and scan toward the lost visual field. Here's why. Homonymous hemianopsia means both eyes lose the same half of the visual field, for example, the right half. The goal of rehabilitation isn't to fix the deficit, but to teach the brain to compensate for it. Encouraging the client to turn their head and scan toward the blind side helps retrain visual awareness and prevents injury. The other options are all unsafe or ineffective. Discouraging eyeglasses removes visual support. Placing objects or approaching from the blind side can startle the client or lead to falls. Always approach and place items on the intact side, where the client can actually see them, while encouraging scanning to the opposite side. Here's your quick NCLEX alert. Remember the phrase, encourage scanning toward the blind side. That's how you know the client and family understand the concept. Common traps include placing items in the impaired field, approaching from the blind side, or removing corrective lenses. And here's your clinical coach takeaway. In real care, keep the environment consistent. Place furniture and the call light on the intact side. Encourage slow, deliberate scanning during meals or ambulation. Use simple verbal cues like, look to your left before standing up. And reinforce these habits often. Consistency builds neuroplasticity and confidence. Alright, that's question 7. Let's keep the learning going and move to the next one. Here's a highlight the text style question that tests your ability to recognize adaptive versus maladaptive behavior after a stroke. A nurse is evaluating how a client is adjusting to new functional limitations during morning care. Listen to this observation and think about which part shows successful adaptation. The client becomes irritable when family members offer to help, occasionally snaps at the spouse when interrupted during grooming, and seems discouraged when using modified utensils for eating. However, the client consistently uses adaptive equipment while dressing independently, and expresses satisfaction with progress in therapy. Now, which phrase in that paragraph shows successful adaptation to the lifestyle changes following stroke? If you highlighted consistently uses adaptive equipment while dressing independently, that's exactly right. Here's the reasoning. After a stroke, it's normal for clients to move through emotional stages like denial, frustration, and discouragement. But consistent use of adaptive tools and satisfaction with therapy show acceptance and engagement, the hallmarks of coping and successful adjustment. The other cues, irritability, anger, and discouragement, reflect early emotional struggles. Those are understandable, but don't yet show successful adaptation. Here's your NCLEX alert. When you see words like consistently, independently, satisfied, or uses adaptive equipment, that's your signal for successful coping. Words like angry, frustrated, refuses, or discouraged suggest ongoing maladaptive behavior. And your clinical coach takeaway. Recovery after stroke often follows 4 phases: denial, frustration, adaptation, and acceptance. Your job is to recognize when the client has reached that adaptation phase, the point where they use rather than reject help and assistive devices. That's when true progress begins. All right, that completes question 8. Let's continue to the next scenario. Here's an ordered response question, one that tests your understanding of sequence and timing in daily self-care for myasthenia gravis. Before we start, a quick refresher. Myasthenia gravis is an autoimmune disorder that causes muscle weakness because antibodies block the acetylcholine receptors at the neuromuscular junction. Strength typically improves with rest and medication, and weakens with fatigue or incorrect dosing. Now let's see the scenario. The nurse is teaching a client with myasthenia gravis how to plan their day to prevent both myasthenic crisis, caused by undermedication, and cholinergic crisis, caused by overmedication. Now, listen carefully to these actions and think about the best order for safety and effectiveness. A. Take prescribed anticholinesterase medication at the exact scheduled time every day. B. Perform essential chores or activities early in the day when energy level is highest. C. Eat meals 30 to 45 minutes after medication to coincide with peak muscle strength. D. Plan short rest periods between tasks to prevent fatigue. E. Avoid triggers like overheating, emotional stress, or overeating. Pause for a moment. What sequence would you follow to keep this client stable throughout the day? The correct order is A, arrow C, arrow B, arrow D, arrow E. Let's reason through it together. First, take the medication on time. This is the foundation of care. Consistent dosing maintains muscle strength and prevents either underdosing or overdosing. Second, eat meals soon after the medication peaks, when swallowing muscles are strongest. Third, do important activities early in the day before fatigue sets in. Fourth, schedule short rest periods to conserve energy and avoid muscle exhaustion. And finally, avoid known triggers such as overheating, emotional stress, or overeating, all of which can precipitate a crisis. Here's your NCLEX alert. Timing equals safety. In myasthenia gravis, medication timing relative to meals and activities determines stability. A late dose can trigger a myasthenic crisis, while an extra dose can cause a cholinergic crisis. Here's a matrix grid-style question on safety teaching for clients with Parkinson's disease. A nurse is reinforcing education about fall prevention for a client who experiences bradykinesia and a shuffling gait. You'll review a few of the client's statements and decide which reflect safe practices and which show a need for further teaching. Let's go through them one by one. Statement 1. I can sit down to put on my pants and shoes. That's safe practice. Sitting to dress prevents loss of balance and supports safety. Statement 2. I try to exercise every day and rest when I'm tired. Also safe practice. Regular exercise helps maintain mobility and reduces rigidity, while rest prevents fatigue. Statement 3. My son removed all the loose rugs from my bedroom. Another safe choice. Removing rugs eliminates trip hazards and is one of the best home safety modifications for Parkinson's clients. Statement 4. I don't need to use my walker to get to the bathroom. Needs further teaching. Clients with Parkinson's should always use assistive devices, even for short distances. Overconfidence and skipping safety aids greatly increase the risk of falls due to bradykinesia, rigidity, and postural instability. Here's your quick NCLEX alert. When the question asks for a need for further teaching, look for statements that show risk-taking, overconfidence, or non-compliance with assistive equipment. Clients with Parkinson's must use their cane or walker at all times, especially during mobility tasks. Now your clinical coach takeaway. Encourage slow, deliberate movements. Never rush. Before standing, rock gently side to side to reduce freezing episodes. Keep walkways clear, floors dry, lighting bright, and the call bell within easy reach. Small details make all the difference in safety. All right, that completes question 10. Let's continue to the next scenario.
Here's a highlight the text style question that tests your ability to identify incorrect teaching in a client's self-care statement. The nurse is evaluating a client's understanding of how to minimize pain episodes related to trigeminal neuralgia, a chronic nerve disorder that causes sudden, severe facial pain triggered by even light touch or temperature changes. Now, listen carefully to the client's statement and think about which part shows a misunderstanding. Since my diagnosis, I've been trying to change some habits to prevent the sharp facial pain. I've started washing my face gently with soft cotton pads instead of using a washcloth, and I make sure the water is at a comfortable temperature. I also chew on the unaffected side and try to eat foods that are soft and easy to manage. When brushing my teeth feels too painful, I rinse my mouth after meals to keep things clean. But I've noticed that eating very hot soups or ice-cold drinks sometimes helps me feel numb for a while, so I might keep doing that. Take a second. Which part of this statement indicates a need for further teaching? If you highlighted eating very hot soups or ice-cold drinks, that's correct. Here's why. Extreme temperatures, whether very hot or very cold, can actually trigger trigeminal pain by irritating nerve endings. These are classic pain triggers for this condition. The correct self-care measures are gentle and neutral, washing the face softly with lukewarm water, chewing on the unaffected side, and using mouth rinses instead of brushing when pain is severe. All of these reduce stimulation to the affected nerve and prevent flare-ups. Here's your NCLEX alert. When a question asks for needs further teaching, always look for behaviors that increase nerve stimulation, like exposure to temperature extremes, drafts, stress, shaving, or vigorous touch. Correct teaching follows one principle: gentle, consistent, room temperature care. And your clinical coach takeaway? Encourage soft, room temperature meals. Avoid drafts or facial massage on the affected side. Support psychological well-being. Chronic pain can lead to anxiety or depression. And emphasize rest and stress reduction as part of long-term management. All right, that completes question 11. Let's continue to the next scenario. Here's a multiple choice question that tests your ability to recognize the key trigger event for Guillain-Barré syndrome, or GBS. Before we dive in, a quick refresher. Guillain-Barré syndrome is an autoimmune demyelinating disorder in which the body's immune system attacks the peripheral nerves, causing ascending weakness that can progress to paralysis. Now here's the question. A client is admitted with a diagnosis of Guillain-Barré syndrome. Which element in the client's past medical history places them most at risk for developing this condition? Option 1. Meningitis or encephalitis during the last 5 years. Option 2. Seizures or head trauma within the last year. Option 3. Back injury or trauma to the spinal cord within the last 2 years. Option 4.
respiratory or gastrointestinal infection during the previous month. Think about the timeline. What usually happens before the first signs of Guillain-Barré appear? The correct answer is option 4, a respiratory or gastrointestinal infection during the previous month. Here's the reasoning. In most cases, Guillain-Barré follows a mild infection, often viral or bacterial, 1 to 4 weeks before onset. Common culprits include Campylobacter jejuni, cytomegalovirus, Epstein-Barr virus, or Mycoplasma pneumoniae. The immune system's response to these infections accidentally targets the body's own myelin, leading to nerve conduction failure and progressive weakness. The other options, trauma, seizures, or past meningitis, don't have a causal link. So when you see a question pairing recent infection with ascending weakness, always think Guillain-Barré syndrome. Here's your NCLEX alert. Remember this clue. Ascending weakness after a recent infection. That phrase almost always points to GBS. And keep in mind, the main danger isn't paralysis itself, it's respiratory muscle failure. Now, your clinical coach takeaway. Ask every Guillain-Barré patient about recent colds, flu-like symptoms, diarrhea, or vaccinations. Monitor vital capacity and respiratory effort closely. Intubation may be needed early. And reassure families that recovery can take months, but remyelination usually occurs with proper supportive care. All right, that completes question 12. Let's continue to the next scenario. Here's a multiple choice question that focuses on therapeutic communication and emotional support for a client with Guillain-Barré syndrome, or GBS. A client with GBS has developed ascending paralysis and is now intubated and on a ventilator. They're fully conscious, but can only communicate with eye blinks and small facial movements. Which nursing strategy would best help this client cope with the illness? Option 1. Giving the client full control over all care decisions and restricting visitors. Option 2. Providing positive feedback and encouraging active range of motion exercises. Option 3. Providing information, offering positive feedback, and encouraging relaxation techniques. Option 4. Administering intravenous sedatives, reducing distractions, and limiting visitors. Pause for a second and think about what this client is feeling. Aware? Frightened? Unable to move or speak? What does this person need most from the nurse? The correct answer is option 3, providing information, offering positive feedback, and encouraging relaxation techniques. Here's the reasoning. Guillain-Barré causes sudden paralysis, while cognition remains completely intact. That combination produces fear and helplessness. The nurse's most powerful tools here are communication, reassurance, and calm presence. Providing clear information reduces uncertainty and builds trust. Offering positive feedback gives the client hope and confidence in recovery. And encouraging relaxation techniques, like slow breathing or guided imagery, helps reduce anxiety and stabilize vital signs. The other options fall short. Restricting visitors or over-sedating the client only increases isolation and depression. And active range of motion is inappropriate for someone who's paralyzed. Passive movement is what's needed. Here's your NCLEX alert. The GBS client is awake, aware, and terrified, but cannot move or speak. The nurse's role is psychological presence. Explain every step, include family, and validate the client's awareness. Now, your clinical coach takeaway. Establish a nonverbal communication system. Eye blinks, alphabet board, or yes-no cards. Encourage family to stay involved. Gentle touch and reading aloud can provide enormous comfort. Use therapeutic silence.
consistent explanations, and never talk around the client as if they can't hear. And most importantly, remind both the client and family that recovery is expected. Most regain strength over months as nerves remyelinate. Alright, that completes question 13. Let's continue to the next scenario. Here's a drop-down Cloze-style question on neuroanatomy and behavioral assessment. A client has a neurological injury affecting the limbic system, and the nurse is performing an assessment. During the neurological exam, the nurse recalls that the limbic system primarily controls blank 1, and that an injury to this region may cause blank 2. Now here are your drop-down choices. For blank 1, the primary function of the limbic system. A. Orientation and spatial awareness. B. Emotional regulation and affect. C. Motor coordination and balance. D. Auditory processing and language comprehension. And for blank 2, the expected assessment finding if damaged. A. Flat affect with periods of emotional lability. B. Loss of recent memory. C. Difficulty with mathematical calculations. D. Slurred speech and impaired swallowing. Think carefully. What general function does the limbic system control, and what kind of behavior might change if it's injured? The correct answers are blank 1, B, emotional regulation and affect. Blank 2, A, flat affect with periods of emotional lability. Here's the reasoning. The limbic system integrates emotion, motivation, and affect. When it's damaged, you'll often see emotional lability, sudden, unpredictable shifts in mood, or a flat affect, where the person shows little or no emotional expression. Other brain regions handle different functions. Orientation and awareness come from the cerebral cortex. Recent memory is tied to the hippocampus. Motor control comes from the cerebellum, and language comprehension happens in the temporal lobe. Here's your NCLEX alert. When a neuro question links a behavioral or emotional change to a brain area, match it with limbic arrow emotion. And remember the key terms. Affect means the outward display of emotion. Lability means emotional instability, the opposite of emotional control. Your clinical coach takeaway. Expect mood swings or inappropriate affect. Maintain a calm, structured environment with consistent caregivers. Provide reassurance and safety, because clients with limbic involvement can act unpredictably or impulsively. Alright, that completes question 14. Let's continue to the next scenario. Here's a select all that apply question that focuses on safety preparation for a client with a known seizure disorder. A client is being admitted from the emergency department, and the nurse is preparing the room to institute seizure precautions. Which measures should be included in the plan of care? Select all that apply. Option 1. Pad the side rails of the bed. Option 2. Place an airway at the bedside. Option 3. Place the bed in the high position. Option 4. Keep a padded tongue blade at the head of the bed. Option 5. Ensure oxygen and suction equipment are available at the bedside. Option 6. Flush the intravenous catheter to confirm patency. Take a moment and think about this setup from a safety perspective. Which actions truly protect the client during or after a seizure, and which create more risk? The correct answers are options 1, 2, 5, and 6. Here's why. Padding the side rails prevents injury if convulsions occur.
Keeping an airway at the bedside ensures you can insert it before a seizure begins if the client experiences an aura. Oxygen and suction equipment must always be available to maintain airway patency and clear secretions post-seizure. And confirming IV patency gives rapid access for emergency anti-seizure medications if needed. The remaining options are unsafe or outdated. Placing the bed in a high position increases fall risk, and keeping a padded tongue blade at the bedside is no longer recommended. Never insert anything into a seizure client's mouth. Doing so can fracture teeth or obstruct the airway. Here's your NCLEX alert. Always think safety before comfort. When you see a seizure question, focus on the environment, airway readiness, and IV access. That's the NCLEX formula for safety-based prioritization. Now, your clinical coach takeaway. Keep the bed in the lowest position with the call light within reach. If a seizure occurs, turn the client to one side, loosen restrictive clothing, time the duration, and document the recovery period. Never restrain the client and never force objects into the mouth.
Here's a bow tie style case. This means we'll connect 3 pieces of clinical judgment: the critical finding in the center, the nursing actions on the left, and the expected outcomes on the right. Scenario: our client is 3 days post-craniotomy. The nurse suspects that the client may be developing meningitis as a postoperative complication. Step 1. Identify the critical finding. Which assessment cue best indicates meningitis? Option A, a negative Kernig sign. Option B, absence of neck stiffness or nuchal rigidity. Option C, a positive Brudzinski sign. Option D, a Glasgow Coma Scale score of 15. Think for a moment. Which of these findings points most directly to meningeal irritation? The correct answer is option C, a positive Brudzinski sign. When the nurse flexes the client's neck and the hips and knees flex involuntarily, that response confirms irritation of the meninges, a classic sign of meningitis. Step 2. Immediate nursing actions. Now, what should the nurse do right away? Let's review the options. Option 1. Notify the healthcare provider. Option 2. Initiate droplet precautions. Option 3. Monitor temperature and neurological status frequently. Option 4. Prepare for lumbar puncture and cultures. Option 5. Encourage the client to ambulate to relieve stiffness. Take a moment to decide which of these actions you would take first. The correct selections are options 1, 2, 3, and 4. The nurse must notify the provider, isolate the client to prevent spread, monitor for worsening symptoms, and prepare for diagnostic testing. Encouraging ambulation is unsafe here. It increases intracranial pressure and offers no benefit. Step 3. Expected outcomes. Finally, which outcomes tell you that your interventions worked? Let's look at the possibilities. Option 1. The client remains afebrile with stable neurological status. Option 2. Cerebrospinal fluid analysis is obtained to confirm diagnosis and guide antibiotics. Option 3. The client's temperature rises and confusion increases. Option 4. The client reports relief of neck stiffness after ambulation. Pause and think. Which of these reflect improvement rather than decline? The correct outcomes are options 1 and 2. A stable temperature and neurologic status mean the infection is controlled, and obtaining CSF for analysis confirms the diagnosis and directs treatment. NCLEX alert. Remember this classic cue. Flex the neck and the legs flex too. That's a positive Brudzinski sign, the hallmark of meningeal irritation. If you see that sign, notify the provider immediately and start droplet precautions until meningitis is ruled out. Clinical coach takeaway. After a craniotomy, always think about intracranial pressure. Keep the head of bed around 30 degrees. Maintain neutral neck alignment. Here's a multiple choice question that focuses on anticipating and preventing life-threatening complications in a client with Guillain-Barré syndrome, or GBS. Scenario: the nurse is admitting a client who reports an inability to move both legs and tingling sensations rising above the waistline. You already know that GBS causes ascending paralysis, so what should the nurse bring into the room right away? Options. Option 1. A nebulizer and a pulse oximeter. Option 2. A blood pressure cuff and a flashlight. Option 3. A nasal cannula and an incentive spirometer. Option 4. Electrocardiographic monitoring electrodes and an intubation tray. Think about the physiology for a moment. If the weakness is moving upward toward the chest, what's your biggest concern? Airway and breathing. The correct answer is option 4. Electrocardiographic monitoring electrodes and an intubation tray. Here's why. Guillain-Barré syndrome causes rapidly ascending paralysis that can involve the diaphragm and respiratory muscles, leading to respiratory failure. An intubation tray must always be available for emergency airway management. It also causes autonomic dysfunction, which can lead to dangerous cardiac dysrhythmias, and that's why continuous ECG monitoring is essential. The other options may help with comfort or mild respiratory support, but they don't address the immediate, life-saving priorities: airway and circulation. Here's your NCLEX alert. Whenever you see a question about Guillain-Barré syndrome, think ahead to airway compromise and dysrhythmias. Remember the phrase, "prepare for ventilation, monitor the heart." The most essential equipment is always the one that protects the airway or circulation first. Now, your clinical coach takeaway. Keep an intubation tray and suction ready at the bedside. Start cardiac monitoring immediately when the client is admitted. Assess vital capacity at regular intervals. That's often the earliest sign of respiratory decline. And remember, the GBS client is fully conscious but losing motor control, so communicate gently, explain every action, and preserve dignity at all times. All right, that completes question 17. Let's continue to the next scenario. Great work making it through the neurological disorders section. We've covered assessment cues, safety priorities, and nursing judgment for the most common neuro problems, from stroke and head injury to meningitis and Guillain-Barré. Now we shift gears into something equally critical: neuro-pharmacology. This next cluster of questions focuses on neurological medications, the drugs that restore neurotransmitter balance, control seizures, relieve pain, and manage disorders like Parkinson's, multiple sclerosis, and trigeminal neuralgia. We'll look at mechanisms, key side effects, and those all-important NCLEX red flag moments: when to hold, when to monitor, and what to teach your client before the next dose. Remember, in pharmacology, every question is about priority, safety, and timing. Think, what happens if I give it? What happens if I don't? That's how you think like a nurse on the NCLEX. Alright, let's step into the neuro-pharmacology cluster and start with our first medication-based question. Here's a drop-down Cloze-style question on one of the key medications used in Parkinson's disease: Carbidopa, Levodopa. Scenario: the nurse is caring for a client with Parkinson's disease who's prescribed Carbidopa, Levodopa. During ongoing monitoring, the nurse recalls that this medication helps reduce blank 1, but that excessive doses may cause blank 2. Blank 1. Therapeutic purpose. A. Muscle relaxation and sedation. B. Tremor and rigidity associated with Parkinson's disease. C. Cardiac dysrhythmias. D. Seizure activity. Blank 2. Adverse effect of excess dosing. A. Hypertension and tachycardia. B. Impaired voluntary movements or dyskinesia. C. Dry skin and itching. D. Constipation and urinary retention. Alright, take a moment and think this through. What's the goal of Carbidopa-Levodopa therapy? And what happens when the dose becomes too high? Correct answers and explanation. Blank 1 is option B. It reduces tremor and rigidity. Blank 2 is option B. Excessive dopamine causes dyskinesia, those involuntary or jerky movements you might see as facial grimacing, tongue thrusting, or eyelid twitching. Here's why. Carbidopa-Levodopa improves movement by replacing lost dopamine in the basal ganglia, and therefore restoring dopamine balance in the brain. But if the dopamine level rises too high, it overstimulates motor pathways, producing uncontrolled movements instead of smooth motion. That's the sign to adjust the dose, not stop the drug entirely. You might also notice other effects like nausea, dizziness, orthostatic hypotension, or bradycardia, all related to dopaminergic activity. Here's your NCLEX alert. When a Parkinson's client develops involuntary movements after starting Carbidopa-Levodopa, think too much dopamine. Notify the provider. A dose reduction is usually needed. Monitor closely for subtle early cues like lip twitching or facial grimacing before dyskinesia becomes severe. Now, your clinical coach takeaway. Give the medication before meals for better absorption, and avoid high-protein foods, which compete with levodopa for transport into the brain. Warn clients that dark urine or sweat is harmless but can occur, and always remind them to rise slowly to prevent dizziness or fainting from orthostatic hypotension. Alright, that completes question 18. Let's move on to the next neuro-pharmacology scenario. Here's a multiple choice question focused on client teaching and medication safety. Scenario: a home health nurse visits a client who takes Phenytoin for seizure control. During assessment, the nurse learns the client also uses oral contraceptive pills. Which teaching point should be included in the care plan? Options. Option 1. Pregnancy must be avoided while taking Phenytoin. Option 2. The client may stop the medication if severe gastrointestinal upset occurs. Option 3. Phenytoin may decrease the effectiveness of oral contraceptive pills. Option 4. Taking Phenytoin and birth control pills together increases the risk of thrombophlebitis. Think carefully about drug interactions here. What does Phenytoin do to liver enzymes? And how might that affect estrogen levels in birth control pills? Take a second to decide your answer. The correct response is option 3. Phenytoin may decrease the effectiveness of oral contraceptive pills. Here's why. Phenytoin is a hepatic enzyme inducer. It speeds up the metabolism of estrogen, lowering blood levels and reducing the pill's contraceptive effectiveness. Clients should be advised to use an additional or non-hormonal birth control method, such as condoms or an IUD. Pregnancy doesn't have to be completely avoided, but any planning should involve the provider. Stopping Phenytoin abruptly can trigger status epilepticus, and there's no connection between Phenytoin and thrombophlebitis. Here's your NCLEX alert.
Remember this phrase: Phenytoin equals enzyme inducer. Whenever a question involves oral contraceptives, enzyme-inducing drugs like phenytoin lower the pill's effectiveness. If you see breakthrough bleeding or unplanned pregnancy in the question, this interaction is the reason why. Now, your clinical coach takeaway. Stress strict medication adherence and regular phenytoin level checks. The safe range is 10 to 20 micrograms per milliliter. Teach clients about common, harmless effects such as gingival hyperplasia and excess body hair growth. Most importantly, emphasize backup contraception and the need to report any missed doses or irregular bleeding. All right, that completes question 19. Let's continue to the next neuro-pharmacology scenario. Here's a matrix grid-style safety question that blends pharmacology with critical nursing action. Scenario: a nurse in the emergency department is caring for a client with Bell's palsy who reports taking large doses of acetaminophen for facial pain. An acetaminophen overdose is suspected. For each nursing preparation or intervention, decide if it's appropriate or not indicated for this situation. Items to consider. 1. Keep acetylcysteine, also called mucomist, readily available for administration. 2. Monitor liver function tests, ALT, AST, and bilirubin. 3. Insert a nasogastric tube for gastric lavage. 4. Prepare for activated charcoal administration within 1 hour of ingestion. 5. Administer Oranofen for Bell's palsy pain. 6. Prepare Wanfi fluids to support hydration and renal perfusion. 7. Set up ECG monitoring for potential cardiac dysrhythmias. 8. Keep oxygen and suction equipment at the bedside. Take a moment and think through which of these are truly appropriate for acetaminophen toxicity and which are unrelated or even unnecessary. Correct selections and explanation. Appropriate preparations include keeping acetylcysteine available, the specific antidote that replenishes hepatic glutathione and prevents liver damage. Monitoring liver function tests for early signs of hepatic distress. Preparing for activated charcoal if ingestion occurred within the last hour. Starting 1-V fluids to maintain hydration and protect the kidneys. Keeping oxygen and suction ready for supportive care. Inappropriate actions include using Oranofen. That's a gold compound for rheumatoid arthritis, not pain relief here. Setting up ECG monitoring. Acetaminophen doesn't cause primary cardiac toxicity. Inserting a nasogastric tube. Gastric lavage is rarely indicated unless ingestion is extremely recent and massive. Here's your NCLEX alert. Whenever you see acetaminophen overdose, link 3 words immediately: acetaminophen, liver, and acetylcysteine. Early antidote preparation and hepatic monitoring are your top nursing priorities. Remember, the sooner acetylcysteine is given, the greater the liver protection. Now your clinical coach takeaway. Administer acetylcysteine within 8 to 10 hours post-ingestion for best outcomes. Know your toxic thresholds. Therapeutic levels are 10 to 20 micrograms per milliliter. Anything above 50 is toxic, and above 200 at 4 hours means a high risk for liver necrosis. Early symptoms include gastrointestinal upset, diaphoresis, and malaise. Later signs are hepatic tenderness, jaundice, and markedly elevated liver enzymes. Maintain hydration, support oxygenation, and monitor those labs closely. Your vigilance prevents irreversible damage. All right, that completes question 20. Let's continue with the next neuropharmacology scenario. Here's a select all that apply question that focuses on opioid safety and recognition of adverse effects. Scenario:
A nurse is caring for a client who has been prescribed oxycodone for postoperative pain. Which side and adverse effects should the nurse monitor for while the client is receiving this medication? Select all that apply. Options. Option 1, diarrhea. Option 2, tremors. Option 3, drowsiness. Option 4, hypotension. Option 5, urinary frequency. Option 6, increased respiratory rate. Think through the pharmacology of opioids. They depress the central nervous system, so what vital signs or behaviors might drop instead of rise? Take a moment to decide your answers. Ready? Let's check them. Correct responses and reasoning. The correct options are 2, 3, and 4. Tremors, drowsiness, and hypotension. Here's why. Oxycodone is an opioid analgesic that acts on mu-opioid receptors in the brain and spinal cord. It produces analgesia and sedation, but also CNS and respiratory depression. Common side and adverse effects include drowsiness and sedation, CNS depression, hypotension, peripheral vasodilation and tremors or muscle twitching, a neuroexcitatory response. Incorrect options: diarrhea. Opioids cause constipation, not diarrhea. Urinary frequency. They actually cause retention. Increased respiratory rate. Opioids slow breathing, not speed it up. Here's your NCLEX alert. Always remember, opioids slow everything down. Watch for a respiratory rate below 12 per minute, a drop in blood pressure, and changes in level of consciousness. Those are signs of toxicity. Keep naloxone, or Narcan, readily available as the antidote. Now, your clinical coach takeaway. Assess pain relief and sedation 30 to 60 minutes after dosing. If respirations fall below 12, hold the next dose and notify the provider. Encourage hydration, fiber, and stool softeners to prevent constipation. And reevaluate blood pressure and alertness before each administration. Safety first, always. All right, that completes question 21. Let's move on to the next section of our review. Here's a drop-down Cloze question that tests your ability to connect lab values with clinical findings. Scenario: a client taking Phenytoin, Dilantin, to control seizures has a serum level of 35 micrograms per milliliter. The nurse interprets this laboratory value as blank 1 and expects to observe blank 2 in the client. Blank 1, lab interpretation A. Within therapeutic range. B. Below therapeutic range. C. Above therapeutic range/toxic level. D. Critical hypersensitivity reaction. Blank 2. Expected clinical finding. A. Slurred speech and ataxia. B. Nystagmus only. C. No abnormal findings. D. Hypertension and tachycardia. Alright, think for a moment. What's the normal Phenytoin therapeutic range? And what symptoms appear when that level climbs too high? Got it? Let's see how you did. Blank 1 is option C, above therapeutic range/toxic level. Blank 2 is option A, slurred speech and ataxia. Here's why. The therapeutic range for Phenytoin is 10 to 20 micrograms per milliliter. Around 20, you'll first see nystagmus, an early sign of toxicity. By 30 and above, clients develop ataxia and slurred speech, evidence of significant toxicity. Levels over 40 can cause confusion, lethargy, or even coma. Here's your NCLEX alert. Always verify serum drug levels for anticonvulsants. If you see unsteady gait, slurred speech, or rapid eye movements, hold the next dose and notify the provider immediately. Toxicity develops silently and can progress fast. Now, your clinical coach takeaway. Check phenytoin levels regularly, especially after any dose change. Teach clients to avoid alcohol. Practice meticulous oral hygiene to prevent gingival hyperplasia, and take the medication at the same time each day. Phenytoin toxicity is entirely preventable with steady dosing and vigilant monitoring. Alright, that completes question 22. Let's continue to the next neuropharmacology scenario. Here's a highlight the text question that checks your ability to spot the toxic cue hidden inside a patient's statement. Scenario: a client arrives at the emergency department complaining of back spasms. They tell the nurse, "I've been taking 2 to 3 aspirin every 4 hours for the past week because of the pain, but it hasn't really helped." Then they add, "Lately, I've also started noticing a constant ringing in my ears, and it's getting worse." Which part of that statement is the most significant sign of toxicity? Take a moment. Picture what happens when aspirin levels get too high. The toxic cue is ringing in my ears. Here's why. That ringing, called tinnitus, is the earliest and most frequent sign of salicylate toxicity, also known as salicylism. It usually appears when daily doses climb above 4 grams. As toxicity progresses, you may also see dizziness, confusion, headache, fever, and even hyperventilation as the body tries to correct acid-base imbalance. Diarrhea, constipation, or photosensitivity aren't related to aspirin overdose. Those are distractors. Here's your NCLEX alert. When you hear aspirin plus ringing in the ears, think salicylate toxicity and stop the medication immediately. Notify the provider and anticipate serum salicylate level testing. Early recognition prevents progression to metabolic acidosis or respiratory failure. Now, your clinical coach takeaway. Teach clients to limit daily aspirin intake and avoid combining it with other ototoxic drugs like furosemide or aminoglycosides. Encourage them to report tinnitus right away. It's reversible if caught early. And always monitor acid-base balance and respiratory rate in suspected toxicity, because severe salicylism leads to metabolic acidosis and hyperventilation. All right. That completes question 23 and wraps up our Neuro-Pharmacology cluster. Excellent work staying focused through these safety-critical medication scenarios. Here's a matrix grid question that tests your ability to decide which lab findings are safe and which demand immediate nursing action. Scenario: a client with trigeminal neuralgia is taking carbamazepine 400 mg daily. You're reviewing the latest laboratory results to monitor for adverse effects. For each result, decide whether it's within normal limits or requires immediate action. Laboratory findings: 1. Sodium level 140 milliequivalents per liter. 2. Uric acid level 4 milligrams per deciliter. 3. White blood cell count 3,000 per cubic millimeter. 4. Blood urea nitrogen 10 milligrams per deciliter. Think carefully. Which one of these results would make you hold the next dose and call the provider? All right, let's check your reasoning. Only the low white blood cell count of 3,000 requires immediate action. Here's why. Carbamazepine can cause bone marrow suppression, specifically agranulocytosis, aplastic anemia, or thrombocytopenia. When WBC drops below 4,000, infection risk skyrockets. That's your stop and call moment. All other results, sodium at 140, uric acid at 4.0, and BUN at 10, are comfortably within normal limits. Here's your NCLEX alert. Remember this phrase: carbamazepine equals bone marrow suppression.
If you see fever, sore throat, or fatigue in a client on this drug, stop the dose and notify the provider immediately. Implement infection precautions. It's a safety priority. Now, your clinical coach takeaway. Monitor a CBC baseline and periodically throughout therapy. Teach clients to report early infection signs, like chills, mouth ulcers, or sore throat, right away. Encourage good hand hygiene and avoid crowded areas or sick contacts during treatment. These simple steps can literally save lives during anticonvulsant therapy. All right, that wraps up question 24. Let's move on to the next neuropharmacology case in our series. Here's a multiple-choice question that focuses on planning safe, evidence-based care for a client receiving an opioid analgesic. Scenario: a nurse is caring for a client with cancer-related pain who has been prescribed morphine for pain management. Specific to this medication, which intervention should the nurse include in the plan of care? Options. Option 1. Monitor the radial pulse. Option 2. Monitor bowel activity. Option 3. Monitor the apical heart rate. Option 4. Monitor peripheral pulses. Think about how opioids affect body systems overall. They slow everything down: breathing, peristalsis, alertness. So which assessment best reflects the main risk you need to manage day to day? Got your answer? Let's review it together. The correct answer is option 2, monitor bowel activity. Here's why. Morphine decreases gastrointestinal motility, which quickly leads to constipation if not addressed. The nurse should monitor bowel sounds and patterns daily, encourage 2 to 3 liters of fluid per day if tolerated, and promote a high-fiber diet. Stool softeners or mild laxatives such as Docusate may be needed. You should also continue to monitor respiratory rate, level of consciousness, and blood pressure, but bowel assessment is the most specific nursing concern for chronic morphine therapy. Here's your NCLEX alert. Always remember, opioids slow everything down. Monitor for constipation, urinary retention, and respiratory depression. Unaddressed constipation can progress to impaction or paralytic ileus, especially in long-term pain management. Now, your clinical coach takeaway. Instruct clients to report no bowel movement for more than 3 days. Encourage daily ambulation, scheduled toileting, and adequate hydration. And document both pain relief and GI function each shift to maintain that balance between comfort and safety. All right, that wraps up question 25 on morphine and nursing priorities. Remember, opioid safety isn't just about watching the respiratory rate. It's about anticipating what slows down first. Constipation, retention, sedation, these are the real exam clues. Keep thinking like a nurse who's 2 steps ahead of the side effects. That's what separates a safe practitioner from someone who just gives the dose. All right, let's keep going. Here's a highlight the text question. A classic teaching evaluation scenario where you need to pick the correct part of the client statement that shows true understanding. Scenario: the nurse is reviewing discharge instructions with a client prescribed Phenytoin, also known as Dilantin, for seizure control. After teaching, the client summarizes what they've learned. Listen carefully and think, which part of this statement reflects correct learning? Client says, "So, I've been taking my Phenytoin every day like you told me. I figured having a drink now and then isn't really a problem, right? I try to keep my mouth clean and make sure to brush and floss regularly. Sometimes, when I feel a bit dizzy, I think maybe I could adjust the dose on my own. Oh, and when they check my blood level in the morning, I usually take my pill first, so it shows I'm still taking it. Alright, which part of that statement shows correct understanding of the nurse's teaching? Take a moment to think about phenytoin's key side effect and what client behavior helps prevent it. Ready? Let's highlight it together. The correct portion is: make sure to brush and floss regularly. Here's why. Good oral hygiene helps prevent or minimize gingival hyperplasia, one of the most common adverse effects of phenytoin. That's the single correct teaching point in this paragraph. The other statements show misunderstanding. Alcohol use can interfere with seizure control and cause toxicity. Adjusting the dose independently risks overdose or breakthrough seizures. Taking the morning dose before a blood level draw produces a false elevation and defeats accurate monitoring. Here's your NCLEX alert. Think: phenytoin equals gums and serum levels. Teach clients to brush, floss, and see the dentist regularly. Avoid alcohol, and always have their levels drawn before taking the morning dose. The therapeutic range is 10 to 20 micrograms per milliliter. Now, your clinical coach takeaway. Use a soft bristle toothbrush and floss gently to avoid gum injury. Never stop the medication abruptly. Take it at the same time each day. And remind clients to wear a Medic Alert bracelet that identifies their seizure medication. That one small step can save a life in an emergency. Excellent work! That completes question 26. Let's move on. Here's an ordered response question that tests your ability to recognize patterns and prioritize safe actions step by step. Scenario: a client with Myasthenia gravis has become increasingly weak. The provider administers edrophonium, also known as Tensilon, to determine whether the weakness is due to undermedication, a myasthenic crisis, or overmedication, a cholinergic crisis. Your job is to arrange the following nursing observations and actions in the correct order. Steps to arrange. A. Observe the client's muscle strength immediately after edrophonium injection. B. If weakness temporarily improves, identify as myasthenic crisis. The client needs more medication. C. If weakness worsens, identify as cholinergic crisis. The client is over-medicated. D. Discontinue the test and prepare to administer atropine sulfate, the antidote, if cholinergic crisis is suspected. E. Monitor airway and respiratory status closely during and after the test. Think through this carefully. Which step comes first for safety, and how would you interpret improvement versus worsening? Ready? Let's go through it together. Correct sequence: E, arrow A, arrow C, arrow D, arrow B. Here's the reasoning. 1. First, monitor airway and breathing. In both crises, respiratory failure can occur suddenly, so airway safety always comes first. 2. Then, observe muscle strength immediately after the edrophonium injection. You're watching for improvement or worsening of symptoms. 3. If the weakness worsens, it's a cholinergic crisis, meaning too much medication. 4. In that case, stop the test and prepare to give atropine sulfate, the antidote for cholinergic toxicity. 5. But if the weakness improves, it's a myasthenic crisis. The client needs more medication, not less. Here's your NCLEX alert. Remember, Tensilon test equals temporary change in muscle strength. Improvement means myasthenic crisis. Worsening means cholinergic crisis. Always keep airway management and atropine ready during the test. That's the NCLEX safe mindset. Now, your clinical coach takeaway. Keep atropine sulfate at the bedside and monitor breathing throughout testing. Teach clients to take their anticholinesterase medications, like pyridostigmine, at the same time each day, ideally before meals. And avoid drugs that worsen weakness, such as sedatives, opioids, and some antibiotics. All right, that completes question 27. Now let's wrap up this neuro-pharmacology set with one final case that reinforces safe medication monitoring and critical thinking at the bedside.
Here's a drop-down Cloze question that tests your ability to interpret lab data and connect it to a medication's toxic effect. Scenario: a client with trigeminal neuralgia reports taking acetaminophen daily for generalized discomfort. You review the lab results and notice a direct bilirubin level of 2 mg per deciliter, or 34 micromoles per liter. Now think, what does that elevated value indicate, and what underlying toxicity does it point toward? Drop down blanks. Blank 1. Interpretation of result. A. Normal hepatic function. B. Mild electrolyte imbalance. C. Abnormal liver function or hepatic injury. D. Coagulation disorder. Blank 2. Underlying toxic effect. A. Renal damage. B. Pancreatic inflammation. C. Liver cell necrosis or hepatotoxicity. D. Bone marrow suppression. All right, take a second to reason through it. Which combination fits the classic acetaminophen toxicity pattern? Blank 1. Abnormal liver function, hepatic injury. Blank 2. Liver cell necrosis, hepatotoxicity. Here's why. The normal direct bilirubin range is roughly 0.1 to 0.3 milligrams per deciliter. A value of 2 is significantly elevated, signaling impaired bilirubin clearance due to liver cell injury. With acetaminophen overdose, hepatocellular necrosis releases enzymes like AALT and AST, pushing bilirubin levels up as the liver fails to process it. Here's your NCLEX alert. Whenever you see acetaminophen plus elevated bilirubin or transaminases, think liver, not kidney. Stop the drug, notify the provider, and prepare to give N-acetylcysteine, the antidote that protects the liver when given early. Now, your clinical coach takeaway. Teach clients never to exceed 3 to 4 grams of acetaminophen per day. Remind them that many over-the-counter cold or pain medications secretly contain Tylenol, so the total dose can add up fast. Watch for early warning signs: jaundice, dark urine, fatigue, and right upper quadrant pain. These subtle cues often appear before full liver failure develops. Great job! That wraps up question 28 and officially completes your neurological Q&A lecture. You just worked through 28 high-yield NCLEX RN questions, covering everything from neurological assessment and crisis management to pharmacology, patient teaching, and lab interpretation. That's not easy, but neither is nursing. And the fact that you made it here, thinking through every rationale, every clue, every clinical decision, means you're already building the mindset of a safe, confident nurse. If at any point you caught yourself saying, "Oh, that's what NCLEX really wants," then you're right where you need to be. This is only the beginning. At NCLEXReviewPro, we're building a smarter, sharper way to study, with clinical thinking built into every question, rationales that actually teach you, and formats that mirror the Next Gen NCLEX experience. So subscribe, follow, or stick around, because we've got more Q&A sessions, mock exams, visual study guides, and voice-coached lectures coming your way. Study smart, practice with purpose, and when you pass, remember, you didn't cram, you trained. See you in the next one.